Ladies and gentlemen, on behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2023. My name is Michał Macnar, and I have an honor of moderating session of radiology. I would like to cordially welcome the esteemed jury, President of the jury, Professor Katarzyna Gruszczyńska, and members of the jury, Dr. Mateusz Winter and Dr. Magdalena Machnikowska-Sokołowska. I'd like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximum time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are obliged to answer in English. If the discussion is run in Polish, the additional point for speaking in English will be not counted. Additional points for using English are given by me. I kindly ask the jury to assess scientific value, way of the presenting, discussion, on contribution. From every category, you can get 1 to 5 points. So I think we can start our first presentation, which is a chimeral anomaly, prevalences and morphologic aspects in Northeast Romanian population. The presenter will be Maria Bianca Andrei.
Hello, everyone. I will share my presentation now. I hope that you can see it.
You can see it.
Okay. Hello, everyone. My name is Andrei Maria Bianca. I am a medical student in the second year at the University of Medicine and Pharmacy in Iași, Romania. And today I will tell you more about the chimeral anomaly and its prevalence and morphological aspect in the Northeast Romanian population. Here is the table of contents. Maybe you are wondering, what is this anomaly? Well, it is also known as the ponticulus posticus, and it represents an anatomical variant that consists in a bony bridge that connects the posterior arch of the posterior arch and the articular process of the atlas vertebra. It is frequently associated with cervicogenic headache, and the overall incidence found was the 16.7%, being more frequent in the females population than in males. From morphological and clinical reasons, there has been done a new original classification consisting in 5 types. We have the type 1, unilateral incomplete one, type 2, bilateral incomplete, type 3, unilateral complete one, type 4, it is a mixed one, associating unilateral complete bridge with contralateral incomplete bridge, and the last one, the type 5, representing the bilateral complete one. And here in the figure 1, we can see these 5 types. There are also other types of classification. However, one classification does not exclude the other. Instead, they can even coexist. Here in the image A, we have the type 1, the unilateral incomplete one. In the image B, we have the type 2, the bilateral incomplete one. In the C images, we have the type 3, unilateral complete on the right side. I hope you can see my pointer. And on the left side as well. In the image D, we have the mixed one, the type 4, here and here. And in the image E, we have the type 5 that represents the bilateral complete one. Regarding the symptoms, they are mostly caused by the compression of the vertebral artery on its way from the foramen transversum of the atlas to the foramen magnum of the skull. And usually patients that have Kimberley anomaly are presenting with headache, vertigo, diplopia, shoulder or neck pains. Regarding the materials and methods, the study was done in the Department of the Radiology, St. Spiridon County Clinical Emergency Hospital here in Iași, and the inclusion criterion was that the scans to offer a full atlas vertebra visibility, while the exclusion criterion was the presence of craniocerebral injuries. We had the total sample of a total of 487 patients computed tomography scans, starting from January 2019 until December 2019. And we divided these patients in 5 groups by ages. The first group was with people that had less than 20 years old, then 21 to 40 years old, 41 to 60 years old, 61 to 80 years old, and the last group with patients that had more than 81 years old. Regarding the results, out of these 487 patients, we had 240 males and 247 females, with the ages in between 5 to 94 years old. And we found the total prevalence to be 34.90%, meaning that this anomaly was present in 170 patients. And we also found the type 1 to be the most frequent one at about 11.29% of the cases. In the table 1, we have the prevalence of the Kimberley anomaly by gender and morphologic type. And here we can see that male cases were preponderant, 93 out of 240 patients, meaning it was present at about 38.75%. Compared to the female cases, where we found this anomaly at 77 patients out of 247 patients, and the incidence was 31.17%. Also, the type 1, type 2, and type 5 morphological aspects were present in similar proportion in both genders, while the type 3 and 4 were more predominant in males. In the table 2, considering the prevalence based on the morphologic classification, the type 1, which is the unilateral incomplete one, was found to be the most frequent one, as I previously stated, being found at 55 patients out of 487, and the total prevalence was 11.29%. Type 1 is followed by type 2, being present at 8.21% of the cases at 40 patients. Then is followed by type 3, present at 25 patients. Then the type 4 was present at 27 patients, and the prevalence was 5.54%. And the last one, type 5, it was found in 23 patients out of 487, and the incidence was about 4.72% of the cases. The Kimberley anomaly, as an anatomical variant, has a high prevalence in the general population. It varies widely in the literature reports in between 5.1% and 37.8%, depending on the imagistic method used and the age of the group study as well. And here we compared two studies. In the first meta-analyses, they combined both bony samples and patient studies, and the overall prevalence in both studies was pretty similar. In the meta-analyses, was present at 16.7%, and the complete type was more predominant than the incomplete type, 9.3% rather than 8.7%. The study on lateral digital cephalometric radiographs showed the incidence rate of arcuate foramen at about 15.8%, and they also showed that it was more predominant in females than in males. And the authors strongly correlated this anomaly with head and neck pain in these 500 patients that they studied. Regarding the conclusions, this anomaly, Kimberley anomaly, is a common anatomical variant here in Romania, and in order to increase awareness of this pathology, our study proposed, introduced, and used a standardized imagistic and clinically orientated classification. Regarding the age-wise prevalence, the Kimberley anomaly is more frequent in adults and young adults rather than in the elderly population. And here are the references. And thank you for your attention.
Thank you for your presentation. So it's now the time for the questions from our jury.
Thank you for your presentation. I'm pediatric radiologist. For me, important is analysis compare with adult group. So the first, the last slide on the right, but very important is remember that it's variant of anatomical variant. Your group is very big, generally in adults. The next step can be compare young adults and adults, but it's not so rare. But important is significant or only anatomical variant to analyze them together. Thank you for your job. It's very good. Thank you.
Thank you.
I also congratulate you. I think that it is the second as big group as this on radiography. So I think it is a good basis for the publication. Well, I think opposite to Dr. Magda, I think that you could join the group below and after 20 up to 40, because there the numbers were not so high. So maybe this, and I think it was a retrospective analysis. So it was a lot of work to preview all the CT scans. I think that you should also mention something about the methodology of this CT scan, how it was done, and how did you were looking for those anomalies for the publication. But really congratulate, because it is a huge group and a lot of work. Thank you.
Thank you. Thank you so much.
Thank you for the presentation. Again, the sample was big, so it's a good basis to take some conclusions regarding comparative assessment, for example, with other nationalities, because it seems that the prevalence of this anomaly was twice as big as noted by some previous authors, right?
Yes.
For what I remember from the first or second slide. So a comparative analysis with some other nations would be probably interesting. I think the whole group, I mean, the groups divided by those 20-year ranges, the prevalence was quite comparable, actually. I don't know if there was any significant difference measured there. Have you measured the significance of the differences in the prevalence of this anomaly in the groups? Because it seems like it being a congenital anomaly, the prevalence should be similar, and whether the differences were significant, actually. So maybe something for the publication, which I hope you are planning. Yeah, that's it. Thank you. A very nice presentation.
Thank you.
Thank you for the questions. And I'd like to welcome Dr. Oskar Bożek, who joined us online.
Good afternoon. It was a very nice presentation, and yeah, congratulations for your huge work on that large amount of studies that you need to analyze retrospectively. Yeah, very good work. Welcome, everybody.
Thank you.
So it's time for the next presentation. Unfortunately, I have information that the second presenter is not available in this moment. So we can go to the third presentation. So I'd like to inform that jury, now you scored the third presentation. Yeah, we skip the second one for now. So the next presentation is radiation exposure during surgery of supracondylar humerus fracture and Gartland classification. The presenter is Magdalena Skraba.
Yes, I will share my desktop. Is the presentation visible?
Yes, we can see it. You can start.
So, hello, my name is Magdalena Skraba. Me and Aleksandra Mrowiec are representing Medical University of Silesia and University of Eastern Finland. I have the pleasure to present our research project in the topic of radiation exposure during surgery of supracondylar humerus fracture and its relation to Gartland classification. Firstly, I would like to describe basic information of measured and analyzed data. A supracondylar humerus fracture is one of the most common childhood injuries and the most frequent pediatric fracture that requires surgical treatment. The Gartland classification of the fracture is categorized by the severity of the bone displacement. In the table, we can see a description of each type of fracture in Gartland scale with Wilkins modification. In the figure on the right side, all those types are visualized. Treatment of the fracture type 1 is non-surgical and simply a plaster is used, while a method of choice in other types of fracture is surgery. So that further analysis includes only type 2, 3, and 4, which involves surgery. Orthopedic surgery as a treatment of the fracture is performed under fluoroscopy, which involves exposing the patient to ionizing radiation. Children are more sensitive for the radiation than adults because of numerous cell division in their bodies and a higher percentage of hydrated tissue than in adults. Children are 3 times more likely than adults to develop the cancer. Because of this fact, any radiological intervention should be taken into consideration for radiation safety. In this case, our aim of this project was to establish the correlation between Gartland scale and radiation dose during surgical intervention. Our patients were mostly in similar groups. We have 57% of males and 43% of female. Our study group is divided by the type of fracture, and here is a short description of the whole group. Orthopedic surgeries were done with the assistance of a fluoroscopy device, Philips mobile C-arm, in the Department of Trauma and Orthopedic Surgery at the Upper Silesian Child Health Center in Katowice. Gartland scale was taken from registered medical records, and patients were treated between year 2018 and 2022. That parameter to establish the absorbed dose was obtained from medical records that include dosimetric evaluation of the fluoroscopy procedure. And the parameter can be defined as an integral of the observed dose multiplied by the area, and it's expressed by a gray meter square. Here is an analysis of the observed dose. Here we can see that type of fracture 2 and 3 have pretty similar observed dose, but in the same analysis, we can see that observed dose for the type 4 is much higher. For further analysis, we needed to make statistical tests, and for that we used Kruskal-Wallis test, and it indicates that our tests have significant level of correlation between this. The test indicates that results are significant for pairs 2 and 4 and 3 and 4 of the Gartland classification. Between these types, observed dose during surgery correlates with a different type of fracture. What is more, there comes a conclusion that patients were exposed to significantly higher ionizing radiation doses during surgery for fracture 4 than for the rest of the types, because there is no significant difference between type 2 and 3 characterized by the Gartland scale. Here we can see a result on the graph. To fully understand the plot, we have to know what every part of the box plot represents. Inside the box, we have 50% of the data. In our case, it's a dose. And between box and whiskers, it's 25% of data. So in this situation, we can see that for the type 2 and 3, the boxes are in similar variables, but for the type 4, the significance difference is visible. And also we can see the median value and also mean value for each type in the table. To conclude our research project, the study found a correlation between the Gartland scale and the X-ray radiation dose during orthopedic surgeries. And in this case, we have to consider taking any kind of surgical intervention for the fracture before actually making the surgery, and count it as highly percentage of the dose that the patient is absorbing. And here are references. And thank you for listening, and we are welcome to any questions.
Thank you for your presentation. It's time for the questions from the jury.
Well, thank you for the presentation. I have one big question, which unfortunately wasn't the subject of your presentation, but maybe it will be something that you will look into next time. I assume that this great difference in the dosage that the patients receive is caused by the severity of the fracture. And so probably these surgeries require a longer time of the procedure and thus the greater dosage.
Yes, that's true. And because the severity is important for the scale, it's also why the surgery for the most severe case is the longest one. And of course, then the dose is higher.
Okay. So maybe it's just this simple answer to my questions, but I was wondering if there are any additional things that make this procedure longer and the dosage of the radiation greater. Maybe, I don't know, maybe some specific problems that the surgeons run into during those procedures.
Of course, the parameters of exposure might be different in this situation for the fourth type, but mostly it's because of the longer procedure.
Mm-hmm. Okay. Some maybe additional views, angles. Maybe that would be interesting to look into and, provide some more specific information. But I'm not a surgeon. I don't know much about kids as well and the fractures. So yeah, thank you very much. It's a very interesting one.
Congratulations, very important topic, the irradiation during the surgical procedures in children. It is a serious problem and we should do everything to avoid it. So I think that your work is really very important. And the same, because I think that the complication of the procedure is correlated with the time of the irradiation. And there are those data about the time of the irradiation in the machine and in the protocol. So it would be nice to correlate it also. Mm-hmm. But do you have any idea how to decrease the irradiation, or it is? I think that there is such a problem that the success of the surgery is the most important thing. So maybe the irradiation is not as important in those complicated cases.
In this situation, it would be very hard to shorten the procedure, but I think that a good solution for that would be to use different type of operating the machine, actually, because we can use a constant fluoroscopy or pulsation fluoroscopy, and in this situation the dose is significantly lower. So I think that it would be more significant to try new operating system.
Okay, thank you.
Changing that.
Thank you. We have no more time.
Mm-hmm. Yeah.
I'm sorry. It's very important topic, dose of radiation. It's absolutely easy for us to understand that fourth type is more complicated than others. So the time and reposition needs more dose of radiation. There's no other possibility to observed by surgeon, only by arm C. But in my opinion, you can try to analyze the other step in further. So how important is dose radiation in fourth type fracture group and results and complication after dose radiation in them. Thank you for your very good job.
Thank you.
Thank you very much for the questions and your presentation. Next presentation, number 4, retrospective and statistical analysis of hand and forearm injuries in the Silesian pediatric population, a cross-sectional study of post-traumatic X-rays in 2022. The presenter is Iga Szymańska.
Ladies and gentlemen, okay. Once again, ladies and gentlemen, my name is Iga Szymańska. I represent pediatric radiology, and I am pleased to present to you the results of our analysis of hand and forearm injuries in the Silesian pediatric population. Before I move on to the main point of my presentation, I would like to present the problem of upper limb injuries. They are one of the most common reasons for presenting in the emergency department rooms in the pediatric population. Forearm is the most common site of all fractures among children, accounting for about 20 to even 30% of all fractures, whereas fingers and wrist are the second and the third most common sites of fractures. Despite the high prevalence of upper limb injuries, they still remain a diagnostic challenge, especially those concerning wrist region. Bearing in mind the difficulties in diagnosis of wrist injuries, we conducted a study which aim was to retrospectively analyze the frequency and location of fractures, including the analysis of age and gender in the study group. Our study included over 800 post-traumatic X-rays of the hand and arm in the 2022 at the Department of Diagnostic Imaging. Moving on to the results. As you can see, boys predominated in our study group, accounting for over 60% of the group. And the difference between number of girls and boys was statistically significant. The mean age of our study group was around 12.5 years old. In our study, we noted over 250 single fractures and over 60 multiple fractures, and both numbers were higher among boys. We noted the seasonality of number of fractures. Here you can see the distribution of number of fractures by month. And looking at this distribution, we can see that there was one peak of number of fractures in May and other in September. There was no statistically significant difference between number of fractures in left and right hand among girls, but there was predilection for right hand among boys. In our study, the most common site of fracture in the wrist area were metacarpal bones, accounting for over 1/3 of all fractures, followed by radial bone, which accounted for almost another 1/3 of all fractures. In metacarpal bones, the highest incidence was noted in 5th metacarpal bone, and this type of fracture is called boxing injury. Moving on to the scaphoid bone, as you can see, it accounted for over 7% of all fractures in our study. And I would like to emphasize that its fracture often remains undetected on X-rays. And moving on to the phalanges, most of the fractures concern the 5th finger, accounting for almost half of all fractures of phalanges. What are the conclusions from our study? The highest risk of fractures is among boys, especially those at around 12 years of age. And there is predilection for right hand among boys, but there is no difference between the incidence of fractures between left and right hand among girls. And mostly affected are metacarpal bones and radial bone. Thank you for your attention, and I will gladly answer all of your questions.
Thank you for your presentation. It's time for the questions from the jury.
Thank you. Quite a group, actually. Quite a lot of children in only 1 year. It almost seemed like the main cause of those fractures was school, leaving school and returning to school in May and June and then September. I don't know if I missed it, or did you forgot to show the different incidents depending on the ages? You did conclude with the information that it was the most prevalent in kids, in boys aged about 12 years. But I don't know if you have shown the graph.
No, we don't have that graph, but it was calculated.
Yeah, I know you did it, but
yes,
it will be definitely interesting for me to see. I will definitely ask for it later on. Well, I don't know if I have any questions. It's interesting work. Thank you.
And if I can say concerning your suggestion that most of the fractures are in school, actually our result of the seasonality of fractures was the same results was in other study. It was Dutch study, and they had the same result, like they had lower incidence in the summer. And they said that it's probably not because we have a lower incidence of fractures, but because kids just go somewhere for summer. So those fractures just are
happen somewhere else.
Happen somewhere else, exactly.
Sure. Yeah, thank you. Thank you. That's it. Thank you.
Congratulations at this huge group in only 1 year. I am surprised because I thought that the radial fractures are the most common. And I would like maybe to further develop the work. You could also perform the analysis and correlation of what kind of fractures require the surgery intervention. It would be very interesting.
Thank you for your suggestion.
You know it, and I know that you know. Could you explain everybody what kind of injury in the 5 were so often?
In this age group.
What's its name and why it's so often? And other, why it's worst, and radial, it's different because we analyze only on the right, but radial, it's arm on our, from emergency to our question, yeah?
Why?
You can explain it.
Why this age? You mean like high activity of those kids? Actually, studies show that most of the fractures happen during the activity. So it may be an explanation why boys have more fractures because they engage more in contact sports. Actually, I have seen research in where they compared the number of fractures caused by clenched fist, so probably a fight, and in boys it was around 25% of all fractures, and in girls it was below 2%. So it was very significant. And so to conclude, this group H engages in many sports. Sometimes they just fall. Also, many upper limb injuries happen because of the fall on the outstretched hand. It's the main cause.
Thank you very much for the discussion. It's time for the presentation number 5. Changes and effectiveness of mechanical thrombectomy in acute stroke, a single center study. The presenter is Marcin Ciekielski.
Good afternoon, ladies and gentlemen. I am honored to be. Okay. So again, good afternoon, ladies and gentlemen. I am honored to be here today to talk about mechanical thrombectomy, which is the main topic of this presentation. The stroke is one of the more important and most common causes of death and disability worldwide. And mechanical thrombectomy has revolutionized the way we think about the stroke treatment. This minimally invasive procedure involves removal of a blood clot from an artery in the brain using catheter-based device. The aim is to restore the blood flow to the affected area and prevent further brain damage. Numerous clinical trials have shown that mechanical thrombectomy can significantly improve the outcome for stroke patients, and it is particularly effective for patients who have suffered severe stroke and cannot receive the intravenous thrombolysis. I am thrilled here to present the findings of our study carried out at our Department of Interventional Radiology. Doesn't work. Okay, so our study focused on retrospective analysis of medical records of patients that underwent mechanical thrombectomy for acute stroke at Department of Invasive Radiology in Katowice. We included all thrombectomies carried out between 2018 to December 2022. We evaluated 63 factors, including general patient data, patient condition and medical history, non-laboratory parameters, laboratory parameters before and after the procedure, recanalization success, the rate and type of complications during and after the procedure, and the clinical outcome after the procedure. The aim of our study was to evaluate the outcomes and challenges for mechanical thrombectomy carried out in treatment of acute stroke. The statistical analysis of collected data was conducted using statistical software. Normality of distribution was obtained, obtained result was assessed using the Shapiro-Wilk test and quantile plot. For comparison of dichotomous variables, the chi-squared test of any expected frequency was less than 5. The Yates-corrected chi-squared test was used. For comparison of variables on interval scale, analysis of variance with 2-case post-hoc test was used for normally distributed variables, and Kruskal-Wallis ANOVA for variables with non-normal distribution. A p-value less than 0.05 was considered statistically significant for all tests, and special thanks to Professor Alexander Owczarek for providing assistance with statistical analysis. Our study population consisted of 118 patients, and 52% of them were female. Average age was 70 years, with standard deviation of 17 years. The predominant symptom observed in our study was paresis, especially hemiparesis, which accounted for nearly 90% of our enfeeblement. The symptom that occurred second most frequently was speech impairment, with aphasia being the most common form observed. And the third most common symptom observed was facial nerve palsy, which was found to coexist ipsilaterally with hemiparesis at most cases. The other observed symptoms were compulsory eye fixation, compulsory head tilt, plegia, unconsciousness, nausea and vomiting, and anisocoria. The most frequent location of occlusion was the middle cerebral artery, with slight predominance on the left side. The second most frequently affected area was internal carotid artery, and the third most frequent affected area was basilar artery. Our study group was divided into 3 subgroups depending on the success of the procedure. The first subgroup comprised of 29 patients with unsuccessful removal of the thrombus, which was due to inability to catheterize the vessel, which was the location of the thrombus, or the structure of the thrombus, which made it impossible to retrieve. The second subgroup consisted of 42 patients, which either with a partial success of this procedure, which either was caused by partial removal of the thrombus or minor complications during the procedure. And the third subgroup consisted of 47 patients with full successful removal of the thrombus. And the most frequent complication observed in our study group was partial reperfusion of the vessel, which was often caused by a multifocal location of the thrombus. The second most frequent complication observed was inability to remove the thrombus, and the third was inability to catheterize the vessel. The other ones were hemorrhagic transformation of ischemic stroke and disseration of the blood vessel. Our study demonstrated that the average time interval between symptom onset and intravascular intervention was 3.6 hours, with 1.8 hours of standard deviation, and there was no significant correlation between this time interval and the success of intervention. Intravenous thrombolysis, bridging to mechanical thrombectomy, was not correlated with success of intervention. The symptom most strongly associated with poor outcome was the upper limb paresis, which only with this symptom only being present in patients with the no success outcome. The occlusion location that showed the most favorable outcome was the middle cerebral artery on the left side. There was no strong correlation between the NHSS score at admission and the outcome of patients. And there was a significant correlation between observed between the death of patients and unsuccessful intravascular intervention. In conclusion, our study found out that mechanical thrombectomy is an effective method to treat acute stroke, and improving patient selection and exploring new technologies are crucial for enhancing the safety and efficiency of mechanical thrombectomy and improving patient outcomes. Thank you for your attention.
Thank you for your presentation. Is there any questions for the authors? Maybe from Dr. Oskar Bożek.
Okay, thank you for this excellent talk. That's a really important topic, which is correlating in what's ongoing, yeah, in current stroke treatment. Have you tried to compare the results, the outcome of the procedure to the major trial studies which are ongoing in Europe and elsewhere in the world? Are we, so the single center that you are analyzing, better than the average or worse?
So the big studies that were conducted at the Europe or United States claim that the successful rate of intravenous of mechanical thrombectomy is around 75%. So our study was about 70%. So it's comparable to the average median of the studies conducted.
Yeah, thank you. Yeah, that's it's good not to be worse, yeah, than the average in the world. Thank you for the study. It's essential, yeah.
Okay, and moreover, the procedure is performed from 2017? 18, yes. So that's our first 4 years, and I think that's a great information.
Important remark. Okay, yeah. So thank you for the work. It's a huge topic, yeah, and there's many factors to be analyzed here. I'm interested about the left MCA being better than the other vessels. That's interesting. Yeah, actually, why left is better, as it was statistically significant, as is shown in the results. Any idea why was it statistically better than the right one? Really? Yeah.
In our study group, the MCA on the left side was the most common site of occlusion, and also the M1 segment was the most common segment on the left side. So maybe this is a big vessel in the M1 segment, so maybe this is the important factor that played that role. That on the right side, the segments M2, M3, and M4 were more common on the right side than on the left.
Okay, so it might be the group bias. Yeah. Okay. Yes. Thank you.
Congratulations. Very important work. Thrombectomy really, as you said, revolutionized the treatment of patients with stroke. And I am once again surprised, because I was sure that the time will be the main factor affecting the result of the thrombectomy. So I'm really surprised. Did you try to correlate it with the CT scan, with asset score, for example?
We wanted to initially, but the aspect score was not calculated at our department normally. In some cases it was, but normally it wasn't. So it was hard for us to calculate it by ourselves, so we couldn't correlate it. But with the time of intervention, the longest time between the onset of the symptoms to the intervention in our study was 13 hours, and the intervention was successful. So maybe the time isn't the most important factor at all.
Yeah, and when you mean the success or not successful or not successful, it is the radiological result, not the clinical result.
Yes.
Then you correlate it with also with the, for example, with death ratio. So yes, it is also very important.
Yeah, so it's important to try to make the results objective. Yeah, so in terms of successful reperfusion, the MT-TICI score should be used. Yeah. On the other hand, we are perfectly aware that interventional radiologists haven't put the results in the reports, so that's why it was impossible. Anyway, it's essential to get the objective result, like a difference in NIHS or NTC, yeah, in terms of reperfusion. Thank you for the example.
Thank you.
Thank you for your presentation, for the discussion. Unfortunately, I get an information that the author of the second presentation will not come to us and not log in. So the organizing committee decided to disqualify this work. All the submitted papers have been presented. We congratulate all the presenting authors and participants of the radiology session. At this point, I would like to ask the Professor Gruszczyńska for a few words to sum up the session.
Thank you very much for inviting me once again. It is always a great pleasure to listen to your work and to be sure that you are interested in radiology. Well, I would like to say that if it is a radiological session, we should pay a bit of attention on the methods, radiological methods which are used. So a bit of what kind of scanning, what parameters of scanning, it would be very, very nice. And also what was important in the last work, to try to correlate the image with the clinical result. Or the consequences, clinical consequences. Of course, it is very difficult in retrospective data, and it also would require some help from the clinicians. However, it would be very, very nice. I'm delighted. Thank you very much.
Professor Gruszczyńska, thank you for these words. I'd like to cordially invite you for the decoration, the closing ceremony of the SIMC 2023 conference, which we held in Effie Hall today, 4:15 p.m. On the behalf of the Students' Scientific Society, I would like to thank you all for the participation on this session, and I hope we will see next year. Thank you very much.